Welcome to the second video in our Regional Anatomy Rapid Revision series. In this video, we are covering the arm and elbow. We will begin with the humerus and arm compartments, then move through the muscles, nerves, and blood supply. After that, we will study the elbow joint, its articulations and ligaments, followed by major muscles, carrying angle, range of motion, and biomechanics. Finally, we'll connect the anatomy to some important clinical condition. As before, this is anatomy revision video. So we are focusing on understanding and remembering the anatomy rather than physiotherapy treatment. Our sequence is bones, compartments, muscles, nerves, blood supply, elbow joint, ligament, muscles, range of motion, biomechanics, and clinical anatomy. At the end, we'll finish with rapid fire examination revision. Let's start with the arm. The anatomical arm is the region between shoulder and elbow. Its main bone is the humerus. The muscles are broadly divided into two compartments, the anterior compartment and the posterior compartment. The anterior compartment mainly contains muscles involved in elbow flexion, while the posterior compartment mainly contains muscles involved in elbow extension. This compartment concept will help us organize almost everything that follows. Let's review the important landmarks of the humerus. Proximally, we have the head, anatomical neck, greater and lesser tubercles, and surgical neck. Along the shaft is the deltoid tuberosity. Posteriorly, the radial groove is an important landmark because the radial nerve and profunda brachii vessels are closely related to it. Distally, we have the medial and lateral epicondyles, the capitulum, and the trochlea. For examination, remember surgical neck, axillary nerve, radial groove, radial nerve, medial epicondyle, ulnar nerve. These three relationships are extremely high yield. The arm has two major muscular compartments. The anterior compartment contains biceps brachii, brachialis, and coracobrachialis. The posterior compartment has triceps brachii and coneus associated with elbow region. The key pattern is anterior compartment flexion, posterior compartment extension, and the major nerves follow the same organization. Musculocutaneous nerve anteriorly, radial nerve posteriorly. The three main muscles are biceps brachii, brachialis, and coracobrachialis. Biceps is a powerful elbow flexor and supinator. Brachialis is a major elbow flexor. Coracobrachialis mainly acts at the shoulder, contributing to flexion and adduction. All three receive motor innervation from the musculocutaneous nerve. The major muscle is triceps brachii. It has three heads, long, lateral, and medial. All three ultimately insert onto the olecranon of ulna through the triceps tendon. The main action is elbow extension. The radial nerve supplies the triceps. The anconeus is a smaller muscle associated with the posterior elbow and assists elbow extension and stability. This is one of the most useful arm compartment relationships to memorize. Anterior compartment, flexors, musculocutaneous nerve, and primarily supplied by branches of brachial artery. Posterior compartment, extensors, radial nerve, and closely associated with the profunda brachii artery. So if you get a compartment question, think anterior equals musculocutaneous and flexion, posterior equals radial and extension. Biceps brachii has two heads, long and short head. The long head originates from the supraglenoid tubercle of the scapula. The short head originates from the coracoid process. The muscle inserts primarily on the radial tuberosity with an expansion called biceps aponeurosis. It has two major actions, elbow flexion and forearm supination. Biceps is particularly effective as a supinator when the elbow is flexed. Brachialis lies deep to biceps brachii. It originates from the distal half of the anterior humerus and inserts on the ulnar tuberosity and coronoid process. Its main action is elbow flexion. A useful point is that because it inserts on the ulna, its action is not dependent on forearm rotation. So, regardless of whether the forearm is pronated or supinated, brachialis remains as an important elbow flexor. Coracobrachialis originates from the coracoid process and inserts on the medial aspect of humerus. Its main actions are shoulder flexion and adduction. But the important anatomy relationship here is the nerve. The musculocutaneous nerve pierces coracobrachialis. That is a very common anatomy question. Triceps has three heads. The long head originates from infraglenoid tubercle. The lateral and medial heads originate from different regions of the posterior humerus. All three insert onto the olecranon, and the main action is elbow extension. The long head also crosses the shoulder, so it can contribute to shoulder extension and adduction. The nerve supply is radial nerve. This is your master table for the arm. For examination purposes, pay particular attention to the relationships between origin, insertion, nerve, and action. The most important patterns are biceps, flexion and supination, brachialis flexion, coracobrachialis shoulder flexion and adduction, triceps extension. Pause this slide and you can take a screenshot if you want to revise or study it. Now let's organize the major nerves. The musculocutaneous nerve supplies the main muscles of the anterior arm. Radial nerve supplies the posterior compartment. Median and ulnar nerve pass through the arm but do not provide major motor innervation to the main arm compartments. The ulnar nerve becomes especially important as it passes behind the medial epicondyle at the elbow. That relationship will become important later when we discuss cubital tunnel syndrome. The musculocutaneous nerves becomes the lateral cord of the brachial plexus. It pierces coracobrachialis and then travels between biceps and brachialis. It supplies the three major muscles of anterior arm: coracobrachialis, biceps brachii, and brachialis. Distally, it continues as the lateral cutaneous nerve of the forearm. The radial nerve is the major nerve of posterior arm. It travels posteriorly along the humerus in the region of radial groove. It supplies the triceps and other muscles of the posterior arm. Distally, it crosses towards the lateral elbow and divides into superficial and deep branches. The relationship between the radial nerve and humerus is clinically important because fractures of the humeral shaft can affect the nerve. The median nerve travels through the arm without providing significant motor supply to the major muscles of the arm. The ulnar nerve also travels through the arm. At the elbow, however, the ulnar nerve passes posterior to medial epicondyle. That is the nerve you can sometimes feel when you hit your funny bone. This location makes it vulnerable to compression and injury. The main artery of the arm is brachial artery. It is the continuation of the axillary artery after the lower border of teres major. It travels down the arm and eventually divides near the elbow into radial and ulnar artery. The brachial artery is therefore an important landmark both in arm and around the cubital fossa. The profunda brachii or the deep brachial artery is an important branch of brachial artery. It accompanies the radial nerve around the posterior humerus in the radial groove region. Let's put the arm together. Anterior compartment, musculocutaneous nerve, mainly flexor muscle and brachial artery. Posterior compartment, radial nerve, mainly extensor muscles and profunda brachii association. Now let's connect the anatomy with the clinical condition. A fracture of the humeral shaft can potentially injure the radial nerve in the radial groove. Because radial nerve supplies the muscles responsible for wrist and finger extension distally, significant injury can produce wrist drop. Injury to the musculocutaneous nerve can affect the muscles of anterior arm, which can produce weakness of elbow flexion and potentially forearm supination due to weakness of biceps. Sensory changes can also occur over the lateral forearm through the continuation as the lateral cutaneous nerve of forearm. Compartment syndrome occurs when pressure increases with a closed facial compartment. As pressure rises, circulation can become compromised, followed by potential nerve and muscle dysfunction. The important anatomical concept is that muscles, nerves, and vessels are confined within relatively fixed compartments. Now let's move to the elbow. The elbow complex involves three articulations: humeral ulnar, humeroradial, and proximal radioulnar. Together, they allow the major movements of flexion, extension, pronation, and supination. So, although we commonly talk about the elbow joint, anatomically we are dealing with several articulations working together. The humeral ulnar is formed between the trochlea of the humerus and the trochlea notch of the ulna. It is primarily a hinge type articulation. This joint provides much of the stability and movement associated with elbow flexion and extension. The shape of the trochlea and trochlear notch contributes significantly to bony stability of the elbow. The humeroradial articulation is between the capitulum of the humerus and the head of the radius. It participates in elbow flexion and extension and also contributes to mechanics of forearm rotation. The radial head is therefore important not only for elbow but also for pronation and supination. The proximal radioulnar joint is between the head of the radius and the radial notch of the ulna. The radial head is held against the ulna by annular ligament. This arrangement allows radius to rotate around ulna during pronation and supination. The elbow joint is surrounded by fibrous capsule. The capsule encloses the joint complex while allowing the required movement. It contributes to stability together with the collateral ligaments and the bony architecture. Remember that elbow stability is not provided by one structure alone. It comes from a combination of bone, capsule, ligaments, and muscles. The ulnar collateral ligament, or UCL, is located on the medial side of the elbow. It is an important stabilizer against the valgus stress. The ligament has three commonly described components: anterior, posterior, and oblique or transverse. The anterior bundle is particularly important for valgus stability. On the lateral side, we have the radial collateral ligament complex. It contributes to lateral elbow stability. The annular ligament is closely associated with this region and encircles the radial head. Let's make this very simple. Medial side, UCL. Lateral side, radial collateral ligament complex. Radial head, annular ligament. And the UCL is particularly important for resisting the valgus stress. The major elbow flexors are brachialis, biceps brachii, and brachioradialis. Brachialis is a major pure elbow flexor. Biceps is particularly effective when the forearm is supinated and also contributes strongly to supination. Brachioradialis is most effective when the forearm is in neutral or mid position between pronation and supination. So, when asked about elbow flexion, don't automatically answer only biceps. Think of three major contributors. The primary elbow extensor is triceps brachii. Anconeus also assists with elbow extension and contributes to elbow stability. Triceps is particularly important when stronger extension is required. The two major pronators are pronator teres and pronator quadratus. Pronator teres is more proximal and pronator quadratus is located distally near the wrist. Both rotate the radius around the ulna to produce pronation. The major supinators are biceps brachii and supinator. Biceps is a powerful supinator, particularly when the elbow is flexed. Supinator works to rotate the radius into the supinated position. So the simple comparison is pronation, pronator teres and pronator quadratus, supination, biceps and supinator. This table brings together the major muscles affecting the elbow and proximal forearm. The high yield pattern is biceps and brachialis for flexion, triceps for extension, pronator teres and pronator quadratus for pronation, and biceps plus supinator for supination. Pause here if you want to revise the detailed origin and insertion information. Now let's look at the carrying angle. With the elbow extended and forearm supinated, the long axis of the forearm is not perfectly aligned with the long axis of the arm. The lateral division creates the carrying angle. It helps the forearm clear the pelvis during walking when carrying an object. Variations in the alignment can be described using terms such as cubitus valgus and cubitus varus. The main movements we assess are flexion, extension, pronation, and supination. Elbow flexion is commonly around 150 degrees. Extension is 0 degrees. Pronation and supination is around 80 to 90 degrees each. As with the shoulder, exact values can vary between references. Focus on the normal movement pattern and approximate ranges. The normal elbow has different end fields depending on the movement. Flexion commonly has soft tissue approximation end field. Extension has firm or hard end field. For pronation and supination, the end field is generally firm. Remember that end field describes the quality of resistance at the end of the passive movement. Elbow stability comes from three major sources. First, bony stability, that is the shape of trochlea and trochlear notch. Second is static soft tissue stability, which comes from capsule and collateral ligaments. Third is the dynamic stability, which comes from the muscles crossing the elbow. All three work together. During pronation, the radius rotates and crosses over the ulna. During supination, the radius returns to a more parallel relationship with the ulna. The movement occurs at both proximal and distal radioulnar joints. This is an important point. Pronation and supination are not simply movements occurring at elbow. They require coordinated movement throughout the forearm. Now, a small biomechanics concept. Muscle forces create rotation around the elbow joint. The effectiveness of that force depends partly on the movement arm, which is perpendicular distance between the joint axis and the muscle's line of action. So when the movement arm changes with joint position, the torque produced by the muscle can also change. Now let's move into applied anatomy. Tennis elbow, commonly referred as lateral epicondylgia, is associated with pain around the lateral elbow and common extensor origin. The condition is not simply a problem of playing tennis. It can occur with repetitive loading of the wrist and forearm muscle. Golfer's elbow, commonly called as medial epicondylgia, involves the medial elbow region and common flexor pronator origin. So compare it directly with tennis elbow. Tennis elbow is lateral, golfer's elbow is medial. And anatomically, extensor origin is lateral epicondyle, flexor pronator origin is medial epicondyle. The UCL is the major medial stabilizer against the valgus stress. Therefore, repetitive or excessive valgus loading can place significant stress on this ligament. This is particularly relevant in activities involving repeated throwing. The ulnar nerve passes behind the medial epicondyle through cubital tunnel. Because the nerve is relatively superficial at this location, it can become irritated or compressed. So, the anatomical chain is medial epicondyle, ulnar nerve, cubital tunnel. Now, let's combine everything. For the arm, anterior compartment, musculocutaneous nerve, flexor, posterior compartment, radial nerve, extensor. The major artery is brachial artery. For elbow, Humeroulnar, Humeroradial, and proximal radioulnar articulation. The major stabilizers include UCL, radial collateral ligament complex, capsule, and bony architecture. And the major movements are flexion, extension, pronation, and supination. Let's make the high yield facts very quick. Anterior arm, musculocutaneous nerve, posterior arm, radial nerve, brachialis, major elbow flexor, biceps, powerful supinator and elbow flexor, triceps, primary elbow extensor, UCL, medial elbow stability, annular ligament surrounds the radial head, ulnar nerve behind the medial epicondyle, radial nerve, radial groove, brachial artery divides into radial and ulnar arteries near the elbow. If you remember these 10 relationships, you have a clinical strong foundation for arm and elbow anatomy question. The clinical anatomy recap and the high yield rapid fire questions are on the screen, which you can take a screenshot or pause. And if you can answer these without looking back, you have covered the essential regional anatomy of arm and elbow. We will continue this in the next video. So please subscribe and share.